just above the xiphoid. Nice and springy, but if it wasn't, what could be wrong?
Osteoporosis.
Osteoporosis.
Osteoporosis. Young male. If he was an unknown to me, I would not rule out osteoporosis. But I know Cameron. I know he's not a drug addict.
Yeah.
Yeah, there's still time. And so osteoporosis would not, because I don't know if you're aware that the fastest growing group in terms of osteoporosis risk are young males, drug addicts. So it would be different. If I didn't know him and I did that and it's positive, he's going to be definitely checked out anyway. So there's a couple of other things if he was positive in this test.
What about AS?
Ankylosing spondylitis would be my guess with his patient profile. The rib springing test is one of the first tests to pick up osteoporosis. It's also one of the first tests to pick up AS, because the AS targets the thoracic region, including the thoracic joints. The cartilage becomes more rigid in the front. The sternoclavicular joints commonly fuse, at least the male surface, and especially in women, it's going to be the periphery. Hallux valgus.
Wow.
Hallux rigidus is another part of the spectrum. So in the periphery, like in a female, remember we picked up a young runner, oriental girl, and so she should have been extremely mobile. That's all we had for flexion, and when you tested the M film, it was obviously very hard. Same on the other hip. She had this much movement in her elbows. This was the key, because we've realized that she had no male movement in her sternoclavicular joint. Rib springing test was positive. So it's like, have you ever been checked for AS? Like, no, why? Okay, and so she was positive. Any others?
Would you pick up anything different if it had like a Grisel's type of syndrome? Any of those ones that would be degrading types of, or would it feel different with someone with a Marfan's or something like that?
Oh, I see what you mean, a hypermobility. Yeah, you wouldn't feel that here particularly, but you'd pick it up in other joints, for sure. What is it that gives us the spring?
Cartilage.
Okay, cartilage and the rib. Remember? The ribs are notable because they have the smallest ratio of cortical to cancellous bone of any of the long bones. That's also what gives us the spring. Anything else? Give you a clue? When you breathe in, that's an active process. The diaphragm is doing that. When you breathe out, you should not have to use any muscle. Elastin where? No, cartilage wouldn't need, it's got elastin, but it doesn't, that's not the reason it bends. The alveoli, right? The alveolar branches have a lot of elastin in them, and it's that collapses the lungs to breathe out. Partly the ribs as well, and we'll mention that later, in the back joints. But if you have COPD, you lose elastin. Either you've smoked it away or it's been infected away. Either way, you're losing the ability to passively expire, so you start to use muscles. And then, of course, everything starts to go downhill because of the increased resistance in the lungs, because of the loss of alveoli. The blood pressure has to increase in the right ventricle, and then we begin the phase of ventricular failure. A manipulation can trigger a heart attack, and has. We even have an instance where a chiropractic manipulation actually tore 2 coronary arteries off the heart. So if you're going to manipulate, you better be doing this test. If it's positive for any reason, no. This is a classic, again, contraindication for a thoracic manip. Okay, so that would be the, if they're, and also what we're testing here, the joints, the synovial joints. Tell us which condition gives us information of these joints. Tietze. Tietze syndrome? You know what I say, if you learn one new thing on a course, it's worth it.
One new thing.
Tietze syndrome occurs with lower respiratory tract infections, such as acute bronchitis, pneumonia, and you, after the infections settle down, you're left with these swollen sternocostal synovial joints. They can get so big that you can see them through a shirt. And for that reason, the old name, in Britain anyway, the nickname for this was military tunic syndrome, because it looks like the buttons of a military tunic. They have taken synovial samples of this and proven that they have viral DNA within the synovium, and that virus infection stays forever. Like herpes, it has moments where it flares up, especially if you're under duress, and then it remits again. Then it exacerbates, then it remits. It is painful enough for people to think they're having a heart attack. And just in case you don't think this is some historical way in the past, you know Gillian across in the admin building? No? We were looking at her son because he's having chest pain. He'd had medical tests. I think he was applying to be a firefighter, and he was being rejected on the basis of this chest pain. And so we brought him over, and as soon as he stripped off his shirt, you could see these regular bilateral swellings. And so Gillian was here with her son, and I said to him, have you ever had any significant chest infection? And he said no. And Gillian went, well, yes he did. He's a kid. He had a couple of big infections. I said, has he had intermittent pain since then? And he said, yeah, on and off, but this is really bad. And interestingly enough, I said, have you had any treatment for this? He said, yeah, I went to the doctor who injected all of them with Depomedrol, which is an anti-inflammatory steroid. And he said, it's the best I've felt. But it came back, and the doctor said he couldn't keep injecting into the joints. So I'm thinking, yeah. And so I explained Tietze syndrome. And sitting over at this end was somebody on a computer. And the DSC students very often come in, not just with computers, but printers. So they're doing that. And suddenly he goes, I have a copy here. So he hands this guy a copy called Thesis syndrome. So there is an article on the web dedicated to that condition. That's pretty much the picture. Nothing you can do about it. You're going to teach them to ice it when it's painful, otherwise ignore it when it's not painful. We've tried ultrasound, we've tried using ultrasound to drive in, oh, what's that chemical? I've lost it. Anti-inflammatory.
Dexamethasone.
That doesn't sound like it at all. Must be different names. But anyway, we've tried that. Nothing works. And once you've got it, like herpes, you've got it for good. Okay, so this test will also pick out that whether they're the cause of the chest pain. Obviously, fractures of the rib or the rib cartilage, this will go, yeah, that's the pain in my side. So now you've got to palpate where the pain is, palpate each rib. First thing you're going to come across is this ridge. This is the ridge between the bony part of the rib and the cartilaginous part as it's going up. So that's often where a fracture occurs. Because the cartilage doesn't, it's not like this glued together. If you take the cartilage away from the rib, like this, the bony part has a big hollow in it where the cartilage actually fits in. So you don't dislocate that, you fracture it. And then of course the fracture could be somewhere else in the rib. Okay, so that would be the spring test. So definitely doing that if we are contemplating any manipulations on your tummy. Just get your shirt off. And then a very important part of the assessment is going to be the stress tests. In the Petman's extras that you've got, there is a movie dedicated to this assessment. And it's a really, really good movie. It's high resolution. The person actually did it on a ladder looking down. So you get a really good perspective. If you haven't seen it already, check it out. It's numbers, isn't it?
Mm.
I think I changed it, recently, so it should be thoracic stress test. The people who got it over a year ago, it's got 13 numbers on it. That's why I suddenly decided to change it. I could never remember the numbers. Anyway, so here we go. We're going to palpate for hypertonus. That's it. I remember it well. So once I've gone down one side, I only have to check the other side at that level. You don't have to do it, the whole thing again, because only bilateral hypertonus is going to be relevant. So with Cameron we have a problem at 4, 5 and what also looks like 8, 9. He had a positive manubrial test, so one of these, at least one of these, is a unilateral lesion. And one of them could be either another unilateral or it could be bilateral. So I have no option but to do PIVMs. But before I do PIVMs, I'm going to use these lines to do my stress test. Remember that the relative interspace between the spinous processes is the first vertebra tip below the line. If it's on the line, it cannot be relevant because the rotatorius goes into the base of the spinous process. So there's the interspace. So this first one is the superior vertebra, this one is the inferior vertebra. So I'm going to push the superior one up towards his manubrium, and then I'm going to take the lower one, push that one up. So this is extension. First one was flexion, stress. Remember, these are not PIVMs, they're stress tests. Fixing the superior vertebra and pushing the inferior spinous process up at about a 45-degree angle for side bending. And with all of these, what you're looking for is movement. Any movement. The thoracic spine, as we'll go into more detail on the thoracic course, but the thoracic spine is organized in such a way, thanks to the anterior elements of the rib cage, you cannot produce an isolated movement of any segment unless it's unstable. Unlike the other two parts of the spine, you cannot get an isolated PIVM. So when we do the PIVMs, we're going to be using the entire spine movement to feel the motion. Last one, I'm going above the line now with one hand to do rotation. So that is a rotation right stress, rotation left stress. Stressing the ribs, I'm going to tuck under. The rib costo-transverse joint will be right on the line. So you go under the line and push up, that will fix the transverse process. Then further out, just get as close to the angle as you can, and above the line, fix the transverse process and check out the movement inferiorly. Again, there should be no motion. And then finally, fix the transverse process on the opposite side and see if we can separate the joint. Now that is a very important test for stability. It's not an ominous sign when we have a rib that's moving. It just means that the costo-transverse ligament is not functioning properly. If we look at the results in prolotherapy, sacroiliac joint, when done for instability, pretty much 100% successful. Lumbar spine, 90. Cervical spine, 80. So the more complex joints are getting, the harder it is to stabilize them. But don't forget, these are people who have pretty much had every other treatment and it's failed. We get to the thorax. Up until last year, or a couple of years ago now, up until then, we were getting like 40% of the people that we treated with Prolo better. So obviously we weren't doing something right.
Just curious about the Prolo, because we don't, well, I've never seen a patient who's had it. Are there like established protocols for treatment after the Prolo therapy? Like you wait 10 days or you wait?
No, you can do it the same day if you want to treat them. The idea is that the reason you're going to get involved with Prolo is you manipulate this. And they come back in a week, you have to manipulate it again. And then again, and then again. Refer back to the definition of instability. Either the muscles or the inert tissues cannot hold this into its neutral zone. There's your indication for Prolo. But by then you've already done the exercises, the postural exercises, etc. Everything you need to do. When they go for Prolo, because they're already doing the corrective exercises, your job is just to make sure this stays in its neutral position. So you may still manipulate them after the third injection, but then suddenly you won't have to. But that'll be about 3-4 months. We only inject once every month. And now we're getting 80% better. And the reason is that I came across an article on the stabilizing factors in the thoracic spine. And if you get separation in the front here, then it will double the movement in the posterior joints. That's one thing, but figure this one. If you get increased length or tearing in the costotransverse ligament, the interosseous part, the movement of the segment, the accessory movement, increases 8 times, 800%. There was our culprit. So we've introduced this test, right? And interestingly enough, the one that is invariably loose is this inferior glide, inspiration. So working backwards on the rationale, it's always associated with a segment slipped bilaterally. When the segment slips forwards, the ribs keep moving normally. Not going to get inhibited respiration because of a simple subluxation. So at this level where they're stuck forwards, the rib relatively is every breath being forced into a hypermobile range and begins to stretch the intertransverse or costotransverse ligament. So when you come along and you manipulate it back, the stability that was given by the costotransverse ligament is no longer there, and it keeps slipping forwards. So in discussion with the prolotherapist, we worked out that if you can come down like this, you can get right in between the rib and the transverse process to put in the prolotherapy. You really need to be working with people who know what they're doing here, because the incidence of pneumothorax in prolo is unfortunately too high. And we had an instance of somebody, I think he was even a surgeon, injecting prolo into a joint in the back and actually puncturing the thecal sac. So you need somebody who's been taught with fluoroscopy already, so they know how to approach these structures. So having done that, then we can do the pivens. But we even know the levels we're going to do the pivens, so we're going to focus in on those guys. Okay, so let's review what you're going to have to do. Thoracic slump, upper motor neuron tests, rib springing, stress test. All right, on everybody, so that nobody gets hurt. If you have had a baby in the last 6 months, if you are pregnant, or even if you think you might be pregnant, then you are not a candidate for manipulation. Or if you fit any of the criteria for contraindications that we mentioned the other day, then just politely excuse yourself from being a model. You can manipulate, but don't get manipulated. Okay? Good? Let's practice.